Okay, hello everybody, and welcome for our September Journal Club. And this month we'll be with Cairo University team with Dr. Sameh Al-Nu'mani, Dr. Rasha Abdelkader, and Dr. Yahya. And they'll give an article about reduction mammoplasty using the Finhandley technique or superomedial pedicle. And we'll give now the mic for Dr. Sameh and start introducing his team. Actually, Dr. Sameh, before starting, Dr. Sameh is my senior. We worked for the same department, but in different units. And I am proud to be his junior. Welcome, Dr. Sameh and your team.
Thank you, Salah, for your introduction. And thank you for all the organizers for this great event and great activity. Let me introduce the Journal Club about our prestigious Qasr Al Aini University, Cairo University, Faculty of Medicine, and introduce my team, starting with our senior resident, Yahya Makin, our assistant professor, Dr. Rasha Abdelkader, and me, Dr. Sameh Al-Nu'mani, professor in Qasr Al Aini Plastic Surgery Unit. Today, we are gonna revisit an old technique, quite old. It was 22 years old since Findley started to admit this technique, and it was revisited by new authors. But we have chosen this article to discuss what's with and what's against, and to reevaluate this technique, which is reduction mammoplasty using the superomedial pedicle circumvertical scar. So we are going to hear about the technique, the article, and the criticism from Yahya. Please, Yahya, you can start.
Thank you, Dr. Sameh. It's an honor to be able to present in this meeting. Is the voice and the picture clear before we start?
Yeah. Yes, yes.
Okay, thanks. This is
very clear now, Yahya.
Okay. This is the paper we're going to talk about. It's called the Superomedial Pedicle Vertical Scar Breast Reduction, Objective and Subjective Assessment of Breast Symmetry and Aesthetics. It was published in December 2017. At first, the authors begin by introducing breast reduction and the symptoms of breast reduction, why women seek breast reduction. And then they say that in the last 3 decades, the inferior pedicle wise pattern technique was the most commonly used. And they begin to clarify the criticism for the aesthetic outcomes, such as the bottoming out, which was very common by this technique. And then in 1970s, Lassus described the vertical scar mammoplasty, which was actually later popularized by Lejour. In 1999, Elizabeth Hall Findley simplified this technique and created the technique we're going to talk about today. She omitted liposuction as a step. She did extensive lateral parenchymal reduction instead of liposuction. And she did not stitch the parenchyma of the breast to the pectoralis major muscle in order to keep it hanging up. The possible advantages of this technique is a shorter scar, less scar hypertrophy, and less scar burden, maintaining upper pore fullness through the superomedial pedicle. However, they say that there is no consensus in literature on the correlation between subjective scores of breast symmetry by patients and by reviewers and the objective measurements of breast symmetry. Thus, they created the idea of this paper. They claim that aesthetic surgery of the breast, the outcome, in order to judge it, we need to talk about the shape of the breast, the overall breast proportion to the body build, proportion of the areolar diameter to the breast symmetry and scar burden, and the position of the nipple areolar complex in relation to the breast itself and to the chest. The aim of their study was to evaluate the long-term aesthetic outcome of patients undergoing the Hall-Findley technique or the superomedial vertical scar breast reduction in both patient satisfaction and reviewer satisfaction, which are the subjective measures, and the objective outcome, which are measurements they took, as I will now explain. As for the patients and methods, they called 181 women between 2005 2009 that underwent this technique. Only 160 of them were actually contacted via telephone. Only 40 of them completed the breast Q questionnaire in order to deliver the subjective opinion. And only 31 of those 40 came actually to their clinic to undergo physical examination and standardized photographs in order to present them to the surgical team for the other subjective opinion and to take the objective measurements. They talked about the marking of the procedure. At first, they draw the new nipple position on the breast meridian around 1 to 2 centimeters below the inframammary fold. Then they draw the skin excision pattern in the mosque dome configuration. The medial and lateral limbs were marked using the Lassus maneuver, which are medial and lateral displacement of the breast. And the lower part of the resection, which is the lower part of the vertical limb, was around 2 to 4 centimeters above the inframammary fold, depending on the breast size and the amount of reduction needed. The nipple areola complex diameter was standardized at 38 millimeters in all patients, and the superomedial pedicle width was determined from 61 centimeters. The surgical technique, they did epithelialization of the pedicle, followed by dermoglandular to achieve a thick lateral pillar around 2 centimeters. And then they did on block excision of the inferior part of the breast with direct defattening of the inframammary fold in the mastectomy plane. Then they put the patient upright in a 90-degree position with removal of medial and lateral dog ears from the vertical scar to get a small horizontal scar. And they closed in layers with direct closures of the pillars by 2 ovicral sutures. As for the assessment, as I said, they did objective and subjective assessments. Objective assessment was by measurements, which are the suprasternal notch to nipple, and they said the ideal is 21 centimeters. Mid-clavicle to nipple, ideal also 21 centimeters. Nipple to nipple, which is also 21 centimeters. Nipple to midline, which is 10 to 12 centimeters. And nipple to inframammary fold, which they said is ideal 6.9 centimeters. As for the breast symmetry, they objectively assessed the breast symmetry using 2 formulas at hand, which is at first the difference between suprasternal notch to nipple on both sides, and the percent of difference between the suprasternal notch to nipple on both sides. They define breast symmetry in their paper as a difference of less than 10% between both breasts. As for the subjective assessment, they did 2 sorts of subjective assessments. The first was the breast Q questionnaire for the patients. Those are the domains of the breast Q questionnaire they used. The other subjective assessment was for the reviewers. The reviewers were a team of plastic surgeons, plastic surgery residents, nurses, and interns at their facility. 16-member team. They reviewed the photographs, and then they were asked to grade their impressions on a 7-point scale, 1 being the worst, 7 being the best, in regarding proportion of breast volume to body build, shape and symmetry of the breast, position of the nipple, scar appearance, and overall aesthetic outcome. As for their analysis, they analyzed different correlations between their data. They did internal consistency analysis within the subgroups of reviewers, meaning the data for the senior staff versus the data for the residents and so on. They did a correlation between the medical staff's assessment and the patient's assessment. They correlated between measurements and changes in distances from one breast to another and from one breast to the ideal. The results, they had 40 patients, as I said. Demographically, they only talked about the BMI pre and post surgery and the resected tissue right and left breast, which those are more relevant to us. As you can see, something I want to point. They talked for the analysis. They talked about demographics at first. They had 40 patients. And they talked only about BMI pre and post surgery and the resected tissue in comparison right to left breast. Those are the parameters which will be important to us later on. I would like to point out two things. First, that the BMI pre and post is almost the same, and the resected tissue of the right versus the left breast in one patient as a mean is almost the same. However, the ranges are quite different. They had on the right breast from 40 to 1800 grams, from the left breast from 294 to 1890 grams. The 40 to 294 is quite a difference that we'll need later on. As for the post-operative measurements, they had 31 patients who actually came to the facility, and they posted the mean of the post-operative measurements. Two measurements we'll need, I also want to point out, which are the nipple to inframammary fold distance right and left. They had the mean of 14.5 centimeters. As for the subjective assessment of the patients or the results of the breast Q questionnaire, those are the results they supplied. They had an average of maybe 75 to 80 points out of 100 in the mean, which is quite good there. However, only two parameters reached a level of significance when they analyzed it, which is the breast size compared to the rest of the body, and the question about how do you look in the mirror without closing. Then they talked about one of the most important parts of the paper, which is establishment of a correlation between objective and subjective assessment, which means what the patients see as good, how it correlates to what the surgeons or the healthcare providers see as good. The symmetry, the correlation was moderate, as well as the scars. Breast shape was weak to moderate. Weak to moderate means that one party saw the breast shape as good, while the other one saw it as not good. So the correlation between patients and healthcare providers was weak to moderate, and the overall outcome was weak. The discussion, they say that patient satisfaction from this procedure is multifactorial. Both functional and aesthetic parameters have to be considered. As I said before, BMI values showed no correlation to overall surgical outcome. Breast symmetry correlated highly in both objective and subjective evaluations, and there is no correlation between breast symmetry and the patient's age, BMI, and amount of resected tissue and complications. When comparing subjective breast measurements to patients and reviewers' evaluations, the only correlation was the suprasternal notch to nipple distance. However, both parties gave low scores in the cases of breast ptosis and post-operative breast ptosis, and none of the other breast measurements correlated with the overall outcome they provided. The breast Q questionnaire, all three categories received high rating, which are psychosocial, sexual, and physical well-being. However, the reviewer group had different weights on which they put their evaluation. The senior surgeons, the most important one for them was the nipple to inframammary fold distance and the breast scars. The residents group focused more on the breast shape and nipple positions, and the non-surgeons group, which are the residents or the nurses, they correlated the aesthetic outcome with the proportion of breast volume to body habitus. As I said, patient evaluation was more when they looked in the mirror without clothes. This was the part they deemed more important. And the correlation of the greater patient satisfaction and higher reviewer scores to breast body proportion should encourage the surgeons to seek a reduction technique best providing this proportion, which means that one of their conclusions they draw that it's important which technique the surgeon uses as long as it scores a good breast body proportion based on their data. Their conclusion that this technique yields a good aesthetic outcome with good symmetry is easily reproducible and should be considered the procedure of choice for all breast reductions. As for my criticism of this paper had multiple strengths, which are, that is one of the rare studies, if any, I don't recall any other study doing the same, that statistically correlates subjective and objective assessment of breast surgery. And subjective assessment was done by both healthcare providers and patients, making results stronger. The correlation between assessment of surgeon and patient for the same procedure, choosing it evidence-based to achieve a pleasing aesthetic outcome. And the evaluation of a very popular, easy reproducible procedures that can serve a lot of purposes in breast reduction. The last point is that retrograde analysis makes the author non-biased for the cases they personally operated upon. The paper was published 2017. Last case was operated upon 2009. So it's not very clear who operated on which. So this is considered a third-party evaluation. The study limitations, it was a relatively small sample size, which means that it's inconclusive satisfaction randomness, which means that 160 patients were operated upon, only 40 people showed up. Maybe those 40 were the ones who were satisfied. The ones who were not satisfied did not show up for the evaluation. So it's a bit inconclusive and non-random. It was not a proper vertical scar breast reduction. They said they do a small T, which makes me a bit cautious about the indications for such procedure, whether this procedure is available for any kind of breast, whether it's available for post-massive weight loss breast or only a specific type of patient. The concept of the vertical scar reduction, which is closure of the pillars, was used. However, ultimately, an inverted T skin resection pattern was done. This is seen in figure 2 on the paper, the patient number 2. They had the deficient preoperative data on all patients as regarding the study parameters they study, meaning symmetry, footprint, measurements preoperatively, etc. This is a non-specific evaluation for breast aesthetics. No anthropometry was done. Symmetry was assessed based on the skin envelope only, which I mean by no anthropometry. They assessed the symmetry by only suprasternal notch to nipple distance. And they correlated the results based on this measurement only, which means they based symmetry only on the quality of and the results of the skin envelope, not on any other factor. The ideal standards taken into considerations are now considered stiff parameters. They are superseded by multiple concepts, such as the concept of breast flow, which sees the breast as part of an entire body, not as a breast alone with specific measurements for the breast alone. This means that nowadays breast reduction is considered an individualized procedure. You don't look at the breast alone. You look at the body build, not only the BMI, the breast envelope, the position of the nipple areolar complex, the breast footprint, the arrangement of volume within the breast, whether it's small on the upper pole, on the lower pole. All those preoperative data makes the planning of the procedure highly individualized for every patient. And concluding from that, the breast reduction has become a philosophy where surgeon, not a mere technique, surgeon uses the techniques in his armamentarium to achieve the desired individual aesthetic outcome rather than only reproducing a procedure for every patient, which in some cases may yield a good aesthetic result. However, in other cases, it may not. I conclude my presentation. This is our faculty, Qasr Al Aini Medical School. They say that home is where the heart is, and Qasr Al Aini captured ours. And as always, on behalf of the Department of Plastic and Reconstructive Surgery, everyone is always welcome to experience that with us. Thank you very much.
Thank you so much, Yahya, for the interesting article and the presentation. And now for Dr. Sameh for his comment, and Dr. Rasha.
So would you like me to start, Dr. Sameh, or would you prefer to proceed? Hello, can everyone hear me?
Yes, yes.
Okay, so this is Dr. Rasha Abdelkader. I would like first to thank all the attendees and the moderators for this great opportunity to be here with you today. It was a great presentation by Dr. Yahya, and I think he covered most points. However, I have a few takes on it. To me, the paper itself, the authors totally forgot to mention the advantages and disadvantages of the approach they used in the vertical dome-shaped reduction. They didn't put any criteria. They didn't show us any criteria for the patient selection for the surgery. And what was noted and stated that all patients within the center underwent the superomedial vertical scar reduction mammoplasty, regardless of the preoperative measurements, which were not mentioned, as Yahya pointed out. They only, based on only comparing that to the inferior technique, which as everyone knows, and it does cause bottoming out, they only compared it, they compared the technique as superior to. I personally think in the upper fullness and the upper fullness of the breast, as they said, as it was an advantage of their vertical scar technique, actually does not only depend on the choice of reduction pattern, rather than a combination between how we choose to leave and shape our parenchyma within the designated envelope we design. And sometimes by seeking less scar burden, we can will be faced with outcomes less than optimal outcomes. Another thing that Yahya mentioned was the table where they said that they had the volumes between the right breast and the left breast, there was a discrepancy. So if we think about that, we have at least one patient that preoperatively suffered from breast asymmetry. So whether the symmetry achieved post-operatively for that patient, where 40 grams were removed of parenchyma from one side and 290 grams were removed from the other side. That's of course in the best case scenario. Whether there was symmetrical scar burden on both sides. They only used the suprasternal notch to nipple furtherly to assess that, the suprasternal notch to nipple distance. Another thing was that the authors used the formula, and honestly, I did go back to see the reference to that formula used in order to measure the breast symmetry, and it was not mentioned at all in the other paper, and neither was the technique used. They used something called stereophotography to get the measurements, and the way they analyzed their data was totally different than the formula used here. So I think that was defective, and it should have been mentioned that the authors of the paper specifically formulated that formula, chose that formula in order to account for the breast symmetry. Also, breast asymmetry has a lot of parameters, and here they only used one parameter of the skin envelope design, which is a suprasternal notch to nipple. Another point, they mentioned the volume. The volume was mentioned during the paper, as they took to calculate the volume that's going to be removed. However, we did not have they told us what they removed, whereas what is very important was what was left. So I think that was another deficiency that had to be addressed, and they had to, it had to be clarified what was left within the breast, not what was removed, and according to what this removed amount was calculated. Then they said another point that really raised question marks to me was the direct defattening of the inframammary fold area. As we know, of course, this by definition will cause like parenchymal bottoming out, or by default it will end up in a problem, which is apparent in some of the pictures in the article. Also, there was an increase in the inframammary nipple to inframammary fold, which was not at all addressed by any means. They said that the average or mean distance was 14.9 centimeters or 14.6, which is, at least in the best case scenario, is like 5 centimeters more than the maximum nipple to inframammary fold distance as per breast measurements. Another thing was that the BMI, they said it was a very important pillar of the paper, that the author mentioned that in contrast to common belief that patients do lose weight post-operatively or post-reduction, that this did not occur within all the patients that did arrive for the secondary assessment. They all maintained the same BMI. And by that the surgeon should fashion the breast according to the body habitus the patient presents with. However, by the measurements available in the paper and how the breast reduction underwent, I do not see how the body mass index, how the body habitus or the body mass index was put into consideration when designing the reduction pattern or the amount of breast parenchyma to be removed and the position of the nipple areolar complex, nipple to inframammary fold, etc. And that's mainly my concerns about the paper, and some like highlights that I was actually intrigued to see. Otherwise, yes, there was no correlation whatsoever. There was any literature covering the point of comparing patient to objective to subjective assessment and patient's assessment to surgeon assessment, which was not mentioned before. No one has ever actually done it. However, another important point that Yahya did mention was that only 40% of the patients did fill the queue, the breast queue. However, they stated further on that only 31 of those showed up for photography and assessment. So that only covers 19% of the whole cohort of 160 patients, which in best case scenarios, just like the author said at the end, that he does see, and it can be biased because those patients presenting to the, agreeing to undertake the Q test or come for a visit in the clinic were those that were satisfied. So by that, we're only comparing 90% of the whole study. And another factor would be that most patients probably would have been satisfied to go back. Another thing he mentioned, that those patients were all done in one center that was public funded, like governmental funded or I think insurance covered center, and it was not a private practice center. So I was just wondering if that had that actually had an influence on the choice of reduction or the choice of study and the patient satisfaction overall, because it would be different. Just like he mentioned something very simple, that was in BMI within the private practice was much lower in the author's private practice than in the study, those seeking to go to the public or governmental funded hospitals. That's about it, and thank you very much, and I'll give it to Dr. Sameh from here.
Thank you, Dr. Rasha. Dr. Sameh, please, your comment.
Thank you, Yahya, and thank you, Rasha, for the very good criticism of the article. So they left for me very few points to talk about. But let's be systematized. I talk about 2 points about the structure of the article, then about the scientific content of the article. First, about the structure of the article, I think the demographic data of the patient pre and post-operative, they were lacking a lot. They were lacking about the assessment of symmetry before the operation, because the main point you are criticizing, it was assessment of the symmetry post-operative. So you have to assess the symmetry pre-operative. The cohort of choice of these patients, he didn't state that he categorized patients for choice of the superomedial vertical scar. So I wonder if every patient can suit this technique. I think it's not, because we have a lot of patients which have criteria against the choice of this technique. This point I'm gonna to delay for discussion of the scientific part of the article. But I wonder if every patient can undergo this technique. I guess not. For your opinions also. Again, this article was retrospective case series study. Tackling a technique was discussed before by Fendley, 1999. It was 20 years ago. So it's not accepted after 20 years to do a level 4 evidence-based study, retrospective case series, again on the same technique. I was waiting to do a control technique to rise in the level of evidence, level 3 or level 2, either control studies or meta-analytic studies, but he didn't mention that more than he did case series, again, case series, and assessment. It's nothing new after Fendley. Opposite that, Fendley chosen a cohort group. She was totally right, and she was totally decisive that I'm gonna to do the group with BMI group with breast criteria or characteristic group. They didn't say that. They didn't every breast coming to their center doing circumvertical superomedial breast reduction. Now to go for the science. I not increase in talking, but when you are talking about any technique for breast reduction, you have to talk about 4S. Safety comes first, then shape, size, and symmetry. The are 4S when you are criticizing any technique for breast reduction or mastopexy as well. He didn't mention at all about the safety of this technique, even for large breasts, nipple areola complex, greater distance greater than 40 cc from the suprasternal notch, or mastotic breast or fibroadenotic breast. I consider high risk group that safety may be endangered using this Pedicle technique, even circumvertical. Regarding shape and size, he just criticized the shape by dull measurements regarding suprasternal notch to the nipple to inframammary complex, which they are considered bidimensional measurements. He didn't consider the upper pole fullness, the nipple to inframammary fold distance and fullness. He didn't consider the lateral and medial fullness. He didn't consider the line between the clavicle and the nipple. He didn't even consider the position of the nipple and areola, which is revisited by Fendley in her book about the concepts in breast reduction, that she herself criticized the determining nipple and areola complex using the inframammary fold. And she supposed to relocate the nipple and areola complex using the upper breast border, which is the most appropriate, because some breasts are low printed and some breasts are constricted, high printed. So the inframammary fold can be abnormal from the start, so you cannot rely on while determining the nipple and areola complex. Again, for symmetry, and he didn't mention in discussion a very good paper about symmetry, which is the Blondil group regarding symmetry. When you assess symmetry of the breast, you have to assess symmetry of the conus, symmetry of the breast envelope, and symmetry of the footprint. he just stated about the symmetry of the envelope using the measurements he used, but he didn't mention about any symmetry of the conus, either pre-op or post-op. As Dr. Rasha said, it is the most important is how much you leave, not how much you remove. When you measure how much you removed in grams, it's just for medical legal, it's just for following the insurance, not for any importance about the breast reduction. I know there are some articles talking about the major you resect for breast reduction, the less safe your technique, but I think it is a very weak paper and we remove a lot of volumes. Using a good technique, it will be safe as well. Again, very important point. Every case of the paper, of the cases presented in this article was suffering from bottoming. You know that bottoming is classified into two components, skin bottoming and conus bottoming. Skin bottoming due to long nipple to inframammary fold distance. And they stated that they already have long distance. I don't know whether they consider it as an advantage or disadvantage, but they stated at the last that the main distance post-operative was 14 plus. And they are by definition, it is a glandular ptosis, as you all know. Another very important cause of bottoming in his cases, or in the group cases, that they defatten the inframammary fold. I don't know whether he was mistaken in language, as he stated the inframammary fold was defattened. I think the most appropriate word to say, the defattening is done till the inframammary fold. You don't have to disrupt the inframammary fold unless you open the room for the breast glandular tissue to fall down, producing more bottoming. So I think most cases of this study was suffering from bottoming out. Another very important point that, in this point, I criticize Fendley herself, that she do direct excision of the pillars, whether lateral or medial pillars, instead of liposuction. In my practice, I consider liposuction is the very best technique for excision, guaranteeing better skin redraping. You know all that vertical breast reduction depends mainly on skin redistribution and skin redraping for the horizontal skin excess. So direct excess will produce definitely dog ears that he was trying to correct in most of cases, as Lassus did in his earlier trials for vertical breast reduction. So in my practice, I consider liposuction is a very great tool or armamentarium for correcting or guaranteeing better skin redraping, especially in the lower part or the vertical excess part, not in the whole pillars. I know someone will tell me it is very dangerous to make liposuction in the medial pillar because it is the flap carrying the nipple and areola. I'm telling about liposuction in the inferior triangular part of the vertical excess. Lastly, I want to say that no standalone technique for breast reduction. I think each case can suit a technique for breast reduction. So you don't have to learn only one technique and making it suitable for all breast reductions, because we may have large breast, huge breast, fibroadenotic breast, lateralized breast, medialized breast, even constricted breast, and you didn't notice because it is subclinical. But you have to select these cases, and they can only be corrected by even ancillary lipofilling after you finish your technique. Finally, this paper is very good, but I think we need more control studies. We need to compare with other techniques, and there are many techniques better than the superomedial. If we consider superomedial is a very safe technique for carrying nipple and the areola, but the skin excision pattern, which is the vertical scar, is not suitable at all in all breasts. But I think most of the breasts, especially huge breasts, can be done using the wise pattern technique rather than a circumvertical technique. Thank you.
Thank you, Dr. Sameh. Thank you so much. I have for Yahya, please, from my point of view as the structure of the article, let's start by the title. The title is stating about superomedial pedicle vertical scar breast reduction, objective and subjective assessment of breast symmetry and aesthetics. Do you see that this title is suitable for the aim of the study and the type of the study?
Not really, actually. The title, when I read the title for the first time, I thought there will actually be an assessment. They assess part of the breast symmetry and part of the breast aesthetics, and a very superficial part. The actual breast aesthetics was not addressed properly, so the title actually does not correlate with the results they produced.
Yes, also, yeah. I'm listening. Go on.
They only talked about very small parts, like the measurements, for example. They did not talk about breast aesthetic outcome as a general. They talked about it in the introduction, that this should be done. However, when they actually had to do it, they didn't do it.
Yes, also, Yahya, during through the introduction, you know that you have to review the literature, then you spot out the gap in the knowledge, then you spot your aim of the study. Actually, in the few words before the aim of the study, he focused on the gap that there is no correlation between the subjective and the objective assessment. Then in the aim of the study, the aim was different from this gap. He was not trying to fulfill that. He was trying to assess the long and short-term outcomes and patient satisfaction and blah, 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 without focusing on the main part of the study, the correlation between the subjective and the objectives. And again, if the gap is there is no correlation between subjectives and objectives assessment, okay, why he chose the superomedial pedicle technique? Why he populated it only on one technique and not assessment of all breast reduction techniques? Why he focused only on the superomedial? Okay, if this is the aim of the study and this is the gap in the knowledge. Again, I couldn't spot out throughout the article how he decided the suitability or how matching is the proportion of the breast size to the body size. He didn't speak about any anthropometric measures before and after, even chest circumference. He don't speak about that, chest circumference, breast circumference, and like that. He didn't speak about that. For sample size, for even 160 cases, even if he have the whole cohort to study, it doesn't reflect how many patients with reduction is done for 4 years or 5 years. The duration of the study. For the assessment, he didn't mention about the reviewers. It was the same group of the team who operated or different group or something, because this is some sort of bias for evaluation and test bias. What else I found for study? He said that this is a historical, I didn't got this words, a historical prospective study. This is not a prospective actually, right? What does he mean?
It's a retrospective study.
No, he's writing in the paper that it is in this historical prospective study, right? In the methods, in the abstract.
Okay. This is wrong, of course.
Of course, this is not a prospective actually. This is retrospective. And I couldn't actually catch the meaning of the historical. What is the meaning of historical here? Okay, and again, in the assessment, this sum in the scoring, he have score out of 7 points, okay? And he considers that 4 means satisfied. Actually, 4 in the middle of 7, this means equivocal, not satisfied, not according to Lekart, okay? This is equivocal, not satisfied, not disappointed, okay? It's in the middle. So you cannot consider 4 as satisfied because it's more than 3.5. No, it's not like that. Because if you are starting from 1 to 7, 4 is the middle, so equivocal. It's not satisfied, not unsatisfied. So I don't know why he considers that. For the revisions, and he's speaking about long-term outcomes. I don't know how he assessing the long-term outcomes of the technique after he make revisions. if you do a revision and you corrected some disappointing result, how you consider it a long-term result? Because for each technique, if I corrected my drawbacks of the technique, this was not a long-term result. Do you agree with me?
Yes, of course.
And again, he considers the inframammary fold to nipple as his measures. He's actually the mean measures he mentioned and he recorded. It's double the ideal he mentioned. So I don't know how the patient was and the assessor was satisfied with the result, while it is double the ideal. This is also I couldn't spot out. And the breast size to the body in obese patient. Do you agree with me? For the patient, almost half of the cohort he examined or he tested, most of them is body mass index more than 29 plus. Okay. For me, actually, I am very hesitating to operate on any patient with body mass index more than 30. Actually, I'm thinking too much before doing that, because for these patients, they have a lot of risk, and the risk for post-operative complication is doubled or tripled after body mass index more than 30. So I don't know. And again, he didn't mention about what was the goal of his cohort group. The goal of a patient who is suffering medically and he's seeking for pain relief or shoulder relief, shoulder pain relief, or so on, is totally different from the patient he's seeking aesthetic reduction for proper shape and like that. So it's totally different. For this patient with high body mass index, they will not, and they are suffering of pain of shoulder or something like that. Once they relieve the shoulder, they will be very satisfied regardless the shape, actually, because their main concern and the goal is relief of pain. But for aesthetic patient, I don't think it's the same. Okay, and something else regarding most of the patient, he spotted that this patient was medically reduction rather than aesthetic reduction. So it's totally different. So I cannot take this result he get, even because of the statistical correlation, because of the sample size is even very small. I cannot populate the result for large community and large community of patient and the large size scale. I cannot populate that. I don't know why he concluded this is. And again, he concentrated only on, as you said, he concentrated on the superomedial to suprasternal notch to nipple area complex distance. And he ignoring the inframammary fold to the nipple area complex, and he ignoring other, and or at least he stating that statistically was not significant. From my point of view, I think the most aesthetic point is the position of the nipple area complex on the mold of the breast, where it is, if it is above the mold or at the top of the mold or below the mold. And again, he didn't mention anything about the technique. He's relying only on the pedicle. I see the pedicle is the only thing for vascularity of nipple area complex. But for me, I have never relied on the pedicle for breast reshaping. I'm usually making extra steps to make reshaping of the breast mold. The basics of breast reduction. You have the incision, you have the excision, and you have skin redrabbing. Okay, so you have to consider that, and the position of nipple area complex. It's very important. It cannot only decided by suprasternal notch to nipple area complex. And it's not fitting for all patients the same number, and even you don't have a fixed number. You are adjusting it according to the patient body, and it's different from one to one. It's not stable. Some patients you have to make it 21, 22, 23, even or 24. Okay, it's totally different. This is my point. I don't know if any other have any points of or discussion for others.
Dr. Muhammad.
Yes, Dr. Fawzi. Welcome, Professor Fawzi Hamza. Yes,
Thanks
Professor Fawzi Hamza. Professor Fawzi Hamza is the head of the department in Azhar University.
Thanks for all the team and all the presenter and all the participants. Actually, it is very nice, strong people, and I think you will not leave any points, especially the 5 or the 6 S's mentioned by Professor Sameh. And first, I have to congratulate Makin Junior Yahya. You cover everything about the measurements, about the BMI, about the everything in measurements. But the paper ignore تماما the patient personality. The patient personality in mammoplasty is very, 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 very important. And the husband and partner will. And these are very important 2 factors before touching any breast for mammoplasty. Shukran. Thanks.
Thank you, Professor Fawzi. Dr. Zia, are you here?
Yes, I'm here.
Yes, your comment.
I think so many things have been pointed out already that were deficient in this paper. I feel that any study on the morphology of the breast is extremely difficult. There are no set patterns for a beautiful breast. The only thing that we can measure is symmetry and how pleasing it is to look at by the observer. That is all we have to go by. Beautiful breasts come in a variety of shapes. So just this endeavor by the authors to undertake this study must be congratulated. And I feel all the deficiencies have already been adequately pointed out by all the participants. Thank you.
Thank you. Dr. Wael is here also.
Yes. Hello, Dr. Mohammed. Thank you very much. Hello. Thank you very much for this nice meeting. I do respect what Yahya presented. It's a very good presentation, Yahya. I know it's not strange to do this between these 2 eminent professors, Sameh and Rasha, my dear friends. So it's very, very effective. I have some points to disagree with my friend Sameh. I think, please, as Dr. Zia said, when we look for a paper like this to assess starting from the title and the aim of the study. So I know that you all mentioned that the title is deficient in some points of view, but we shouldn't wait from the author to give us a review article of the technique and the safety and why it is indicated. He should only say why did he use this specific technique for this specific patient. That's why we will jump for the study design and the methodology used. So as you all mentioned in the study design, should it be better to be a randomized control, a comparative study or something like this, to put a proper indication for each technique. Also the methodology done and the statistics done. So according to the title, he said, I think he fulfilled what he mentioned. He didn't put a great title to compare. He just said aesthetic, subjective and objective. Unfortunately, I was unlucky to read the whole paper, but I just heard from Yahya. So as our friend Zaya said, it's very difficult to assess the beauty of the breast. I think also when we compare the results between the patients and the doctors, I think the patient all the time have higher expectations. I think when we use a non-surgical evaluation, we can use a third party, non-doctor, maybe a nurse or something, to say what's the beauty of this breast. But always the patient will be unsatisfied because he has higher expectations. Thank you again for this great meeting. I hope it will be repeated once again. Thank you, Mohammed. Thank you, Dr. Zayan, and all our friends. Thank you, Dr. Sameh and Rashid.
Thanks, Professor Dr. Wael Sar. Professor, we have also Professor Nader Miligi.
Thank you very much. I came late. I'm sorry, but I am enjoyed listening to you. I just finished my clinic now. Thank you very much.
Thank you, Dr. Okay, anyone have any question, please, from the audience? I think there is Basim. He's asking about, I have a question. I recall that new studies have shown the resection volume is directly proportional to post-operative complication, which conflicts with the result of this study. I would like to learn which is right from your experience. Dr. Sameh?
Yes, Mohammed, I think I talked about these points specifically. The resected amount can alter the safety if you remove the most of the amount from the pedicle. But if you remove the amount from the lateral pillars, the medial, the inferior, I think you left a good room for the pedicle to rest on, relieving tension over the pedicle, making it more secure. I read about the papers of that major reduction is accompanied with some morbidity, but I don't think in my practice that major reduction. I think major reduction will, when proper planning of the skin envelope, will make it very safe when using the appropriate pedicle.
Dr. Muhammad?
Hi, Doctor. Yes, sir.
Fawzi.
Yes, Professor Fawzi, welcome.
I'm quite agree with the statement اللي Professor Sameh as regard in the mammoplastic surgeon should learn most of the technique. And I enhance and stated that it is better to start learning inferior pedicle reduction mammoplasty first. If you do inferior pedicle reduction mammoplasty, you can do any type of reduction techniques safely. Shukran. Thank you.
I have a concept that if there is a lot of techniques, there is no perfect technique. Because if there is only one single technique that is perfect, the other will not appear. Okay.
Yes.
So let's agree for that.
Excuse me, Mohammed, I want to add a point.
Yes, sir.
Do you think for all the audience, what is the limit between using the vertical scar or the wise pattern? If there is a definite limit when you plan for the patient that you decide I'll do it with circumvertical or I'll do it with wise pattern, I have 2 points to tackle with to answer this question. That vertical mammoplasty first is a concept rather than technique, that you can do vertical mammoplasty even using the wise pattern. It's just constricting the breast, reducing the breast base toward the center, so producing more projection. The second is the paper I'm fond of about Tibbets, and he made 3 papers, I think 2013, about the skin envelope management, the conus management, and the breast reduction as a whole. And when he addressed the skin management, he reported that there is a vertical excess, which is the difference between the nipple to inframammary fold distance minus the ideal distance, which is proportionate to the breast width. And when it is greater than 4 centimeters, I mean about the excess, so you have to go for the wise pattern from the start. Don't try to redistribute more than 4 centimeters. Another important point that the skin of the massive weight loss breasts is not good skin quality. So I think redistribution of the skin of the massive weight loss breasts is usually ending with failure. So in massive weight loss patients, I usually start with wise pattern, not thinking of skin redistribution.
The skin quality itself in the patient of post-bariatric or post-massive weight loss is totally different from the normal skin of the because it have lost its elasticity and sagging. And again, in this patient with post-massive weight loss, they have a pathology of lateral chest wall excess. And usually this is mistaken for breast skin. Actually, it's a combined together pathology. And I think it's need a separate management, either by excision or extending the scar or doing liposuction or doing something to address this area. And actually to address this area, we're adding for the breast aesthetics and the definition of the shape of the breast actually.
I think that Dr. Mohammed, I just wanted to comment after Dr. Sameh and you, that I have a feeling, especially in this study, that actually the technique was used, the reduction was tailored according to the technique, which actually left us with a very weird comment at the end that patients, a lot of patients ranged within the cup D, and they only went 2.1 reduction in the cup size, which is like an equivalent of 400 grams removal from each side. So this is yes, I agree with Dr. Sameh. Of course, we have to learn multiple techniques because we cannot tailor every patient to fit the technique we have on hand. Saying that, I wanted to ask Dr. Zia, because he mentioned that it was very difficult to compare between like aesthetically, because the range of a beautiful breast between different countries, nations, and cultures is different. However, I personally feel, and two of breast symmetry is, of course, one pillar that we can compare, and in conjunction to that, the fullness of the envelope with the distribution of the parenchyma should be considered as an aesthetic point of view. From any aesthetic point of view, like even if I do think, or if in certain areas they think, for example, in Africa, they think, in certain communities, they think tuberous breasts are beautiful. However, one parameter is the breasts always have to be full, the skin has to be taut, and they both have to be both symmetrical. So I was shocked in comparing the volume, like the skin excision and complete lack of volume measurement was clear, and that was my take on it.
Thank you, Dr. Rasha. Thank you. Actually, as I expected, that article is very debatable, and and I expected that this article will occupy the whole session, and there was no need for another article together with this on. And I would like at the end to thank Dr. Sameh, Professor Dr. Sameh al-Nu'mani, Professor Dr. Rasha Abdel-Qadir, and Dr. Yahya, and all the team of Cairo University, our big house. And I would like to thank all the audience. And if there is no other comment or question, we shall close now because we are in time. Any question? Okay, thank you everybody, and see you next month, inshallah, on the last Tuesday of October, and a new article and a new team, inshallah. And thank you. Goodbye.
Bye-bye.
Thank you.
Thank you. Thank you very much, everyone. Bye-bye.
Thank you.
Thank you.